This last part of the lecture focuses on the United States Preventive Services Task Force, which used to be the gold standard for preventive health guidelines in the US. When I made this lecture in 2024, the biggest controversy was that the panel decided not to make race based guidelines for breast cancer screening. That seems quaint now in 2026. Under the current administration, the future of the United States Preventive Services Task Force is uncertain, and health information coming from the federal government has to be taken with a grain of salt and compared against the same from trustworthy academic and professional organizations. It is now more important than ever to critically appraise data yourself rather than basing your clinical or public health decisions on someone else's conclusion. When reading clinical guidelines, always ask what evidence they're based on and take it a step further. Find the original research and read it yourself. Several high quality research studies, including a large cross sectional study published in 2024, have shown that breast cancer incidence has been increasing in young women since the year 2000. There was a sharp increase in breast cancer incidence among women aged 20 to 49 starting in 2016, with an annual percentage increase of 3.76 every year since. And when broken down by race, the recent data shows that non-Hispanic Black young women have had a disproportionate increase in new breast cancers diagnosed before age 50 since 2016. Despite the concerning increase in breast cancer incidence among young women in recent years, the vast majority of breast cancer still occurs in older women, which is important to consider both when making public health decisions and when providing preventive health care for individual patients.
The mammogram is a well-known screening test for breast cancer. Years ago, women were screened before age 50 even if they didn't have an increased risk, such as genetic susceptibility to breast cancer. Over time, it has become increasingly apparent, based on population-level data, that screening women under 50 with an average risk for breast cancer causes more harm than good. This is partially because younger women's breast tissue is more dense, which makes the mammogram harder to read. The risk of breast cancer also increases with age. The annual incidence of breast cancer in 40-year-olds is about 1 case per 1,000 women, while the incidence reaches about 5 cases per 1,000 at age 65. Another factor is that screenings we use today in modern medicine aren't nearly as accurate as people often assume. Imagine you recently had your first mammogram and your primary care provider informs you that your screening was positive, so you need to come in for additional imaging and a breast biopsy. Intuitively, you may think it's very likely that you have breast cancer based on your positive test results. After all, mammograms are considered to be a highly accurate tool for breast cancer detection. People often incorrectly think if mammography has a sensitivity of 81%, then my positive test must mean I have an 81% chance of having cancer. Remember that sensitivity refers to the number of people correctly identified by the test as having the disease when testing a group of people who are already known to have the disease. It's positive predictive value, not sensitivity, that's helpful in determining the likelihood of disease given a positive screening test result. If we assume you're a 40-year-old woman and use breast cancer prevalence data from a relatively small study that found a positive predictive value of screening mammography of 4%, that means given your positive mammogram, there's a 4% chance you actually have breast cancer. It's likely even lower than that, though. Large international databases yield a positive predictive value of 1.3% for a 40-year-old, although it increases to 9.8% at age 60. The increase in positive predictive value with age is important because it's after age 50, when it nears 10%, that the benefits of screening start to outweigh the risks. If a woman completes screening mammography over 20 years, she has a 25% to 50% risk of receiving a false positive result after being called back for more testing or treatment. Screening causes a significant amount of overdiagnosis and overtreatment because non-invasive ductal carcinoma in situ, which is a cancer that often will not progress to cause negative health effects or death, is often diagnosed with mammography and then treated. Some of these cases do progress, but we don't have a way of determining which ones will, so all these women get treated to be on the safe side. In addition to psychological stress and medical bills, false positive results and overdiagnosis can lead to surgeries, chemotherapy, and radiation therapy for cancerous cells that never would have progressed to invasive breast cancer had they been left untreated. Getting regular screening mammograms for more than 10 years reduces the risk of dying from breast cancer by 0 to 15%, with the most well-designed studies finding the smallest benefit or no benefit. The first table shows breast cancer deaths avoided per 10,000 women screened by repeated screening mammography over 10 years. And the second table shows the harms of one-time mammography screening per 10,000 women screened. When 10,000 women are screened repeatedly over 10 years, 3 deaths may be prevented. These 3 deaths are at the cost of 1,212 women receiving false positive results, 164 women getting breast biopsies, and 10 women having cancer that was not detected by their mammograms. You can see in the youngest age group there's a higher rate of false positives, and more breast biopsies are needed for confirmatory testing. In the 70 to 74-year-olds, there's a lower rate of false positives, and the false negative rate doesn't increase very much. This data is based on women of normal risk, so this does not include women who have the BRCA genes or a first-degree relative with breast cancer. A large cohort study that looked at this data and analyzed the impact of different screening recommendations determined that to decrease the disparity between different U.S. races, Black women should start screening for breast cancer 8 years earlier than the general population at age 42 to have a 10-year cumulative risk of breast cancer mortality of 0.329%. And on the other end of the spectrum, Asian women should start screening 11 years later than the general population at age 61. Native American women fall in between and should start screening at age 57 based on this risk model. But the United States Preventive Services Task Force chose not to make race-based guidelines for breast cancer screening. On April 30th, 2024, the United States Preventive Services Task Force changed their recommendation for women of average risk to begin screening for breast cancer with mammography starting at age 50 to instead begin screening at age 40. This guideline change was intended to help address the disparity in Black women who are more likely to be diagnosed with more aggressive breast cancer before age 50 compared to other racial groups and have seen more increases in incidence of breast cancer, especially since 2016. With this guideline change, the United States Preventive Services Task Force did not make a recommendation regarding breast ultrasonography or MRI in women with dense breast tissue. And the recent data that led to the guideline change begs the question why they chose not to make different recommendations based on race, but instead made a blanket change to the age for all women to initiate breast cancer screening. But they did acknowledge that they made this change to address the inequities in breast cancer stage at diagnosis, subtype, and mortality among Black women in the U.S. Black women are more likely to be diagnosed with breast cancer beyond stage 1, more likely to be diagnosed with triple-negative cancers, which are more aggressive tumors, and Black women are 40% more likely to die of breast cancer compared to white women. Here's what the United States Preventive Services Task Force had to say about this guideline change.
Breast cancer impacts far too many people across the country, and we have long known that screening can help to keep people from dying from this disease. The latest science is clear that encouraging all women to start getting screened when they turn 40 can save even more lives from breast cancer. Black women are 40% more likely to die from breast cancer than white women, and all too often get more aggressive cancers at younger ages. So this new recommendation is even more important to them. Ensuring that Black women start screening at age 40 is certainly an important first step, but yet not quite enough to completely erase or reduce the inequities that we see. We still need more scientific evidence to help us to better understand whether and how additional screening might help the nearly half of all women who have dense breasts. We also need to better understand the health disparities that women face. And we need to better understand the potential benefits and harms of screening women ages 75 years and older. But for now, the most important thing for women to know is they should start getting screened for breast cancer every other year, starting at age 40, since it just might save your life.
The United States Preventive Services Task Force does not recommend routinely screening men for prostate cancer using a PSA blood test. After reviewing the available evidence on prostate cancer screening in American men and grading the evidence based on quality, an independent panel of experts determined that for most men, the benefits of the screening do not outweigh the harms. Even for men ages 55 to 69, the decision of whether or not to screen for prostate cancer should be individualized with a discussion of the potential risks and benefits of this screening. The decision to take into account individual risk factors and patient preferences. You can see from this infographic that out of 100 men who get a positive biopsy, 20 to 50% of these men will be diagnosed with cancer that would never grow or cause harm. But most men who get a positive biopsy then get surgery or radiation, and many are left with erectile dysfunction and urinary incontinence. Of 1,000 men offered PSA-based screening, 3 out of the 1,000 men will avoid cancer that would spread to other organs, 1 prostate cancer death would be prevented, and 5 of those 1,000 men will die of prostate cancer even after surgery or treatment.
My name is Alex Christ. I'm a family physician and the vice chair of the U.S. Preventive Services Task Force. For 20 years, I've seen patients, taught residents, and done research at Fairfax Family Practice and Virginia Commonwealth University. The U.S. Preventive Services Task Force is a group of independent volunteer experts in evidence-based medicine and preventive medicine. We work to improve the health of all Americans by making evidence-based recommendations about prevention. Prostate cancer is one of the more common cancers to affect men. Based on a review of the evidence, what we're recommending in 2 parts is that men between the ages of 55 and 69 who are considering screening talk with their clinician, understand the benefits, understand the harms, weigh their values, and make a decision with their clinician. And we're recommending that patients 70 years of age and older not routinely get screened for prostate cancer. The screening test for prostate cancer is a blood test called a PSA blood test, or prostate-specific antigen. This can be elevated for men who have prostate cancer, but it can also be elevated for many other reasons. What the science tells us is that among men who choose to be screened, about 1 in 1,000 won't die from prostate cancer, and about 3 in 1,000 won't get metastatic prostate cancer. However, we also know from the same science that there are harms from prostate cancer screening. And while a few men will have benefits from screening, many men will have harms from screening. The harms include 3 things. The first harm is false positives. So a false positive means that a man has a high PSA test, but they don't have prostate cancer. That might lead to a biopsy, which can have some complications. The second harm that we think about is what we call overdiagnosis. And prostate cancer is a unique cancer. It grows very slowly. Most men who get it will never know they have it. They'll never have signs. They'll never have symptoms. And they'll only know that they have prostate cancer by getting screened for prostate cancer. We're not very good at figuring out which cancers are overdiagnosed and which ones will progress and affect a man in his life. So these men might get treated, and it might be a treatment that they don't really need. Third harm we think about is the harm from treatments, like surgery and radiation. And that can lead to urinary incontinence and erectile dysfunction. And that can really interfere with a man's quality of life. Now, one of the problems that we have with the science is thinking about high-risk men. So men who are African American or men who have a family history of prostate cancer. Does screening help them any more than an average risk man? We also don't know, do they have greater harms from the whole screening process? We need more studies to know what's right for high-risk men. And for high-risk men, we're saying that our current recommendations apply. The task force recognizes that the decision about prostate cancer screening is a complex and a personal decision. We encourage patients to talk with their doctor and make a decision together about what's right for them. For more information, visit uspreventiveservicestaskforce.org.
Herpes simplex virus can cause sores on the mouth and genitals. In general, HSV-1 infects the mouth and HSV-2 infects the genitals, but these viruses are very closely related and either type can affect either part of the body. Once a person gets infected, the virus will always remain in the body even if no sores are present. When there are sores on the skin, the virus can spread easily between people by skin-to-skin contact. When a patient with sores comes in for treatment, if it is unclear to the provider if the sores are caused by HSV or another type of infection, such as a bacterial skin infection, the sore can be swabbed and tested in the lab to confirm the cause. This testing is diagnostic testing, not screening, because the person in this example already has symptoms and the test is being used to clarify the cause of disease. People with no symptoms of herpes sometimes ask to have a blood test to screen for HSV, but this is not recommended by the United States Preventive Services Task Force. The positive predictive value for HSV2 blood testing in an American is 50 to 75%, depending on the specific test used and the timing during the natural history of disease. This means that if you get a positive test result with the most widely used test, there's only a 50% chance you actually have HSV2. So flipping a coin would be equally effective to predict whether or not you have the infection. Let's revisit the brucellosis example. The prevalence of brucellosis in this part of Alaska is 1%, and the new test you're using as a screening has an 80% sensitivity. When using the 2x2 table method, you can make a fictitious population to help fill in the rest of the table. Let's say there's 1,000 people in the population. We know the prevalence is 1%, so we multiply 1,000 by 0.1 to determine that 10 people in our fictitious population would have brucellosis. Then we subtract the people with the disease from the total population to find how many people do not have the disease. 10% of those with brucellosis will test positive, so we multiply 990 by 0.1 to get 99 false positives. We subtract the false positives from the total population without the disease to get the true negatives. The test has a sensitivity of 80%, so it'll correctly label 8 out of 10 people with brucellosis as positive, and the other 2 who actually have the disease will get negative test results. That means for every 1,000 people screened, 99 will get a false positive test result. So you can provide some reassurance to your patient with a positive result by telling him there's only a 7% chance he actually has brucellosis. Your classmate working in Juneau calls. Her patient has never traveled to other parts of the state and follows a strict vegan diet, but he convinced another clinician to order lots of screening tests for him because he wanted to get checked for everything. Given the prevalence in the local community's wildlife and route of transmission for brucellosis, how does this change your calculations? How should your classmate interpret the positive test result in this patient? Your classmate should interpret this as a false positive. You don't actually even have to do any math. In this example, transmission would be nearly impossible, so the pretest probability was extremely low, meaning that that test shouldn't have even been ordered in the first place, but because it was, that result is not likely to represent a true positive. Test results need to be interpreted taking into account pretest probability. How likely is it that you have the disease before you know the test result? For example, if someone is obese and both their parents have diabetes and they're from an ethnic background with a high prevalence of diabetes, then the pretest probability before getting screened for diabetes is high. Bayes' theorem tells us how to adjust pretest probability to post-test probability. You don't throw out the pretest probability, you adjust to interpret the test results. This brucellosis in a vegan example is a pretty clear-cut case, but in most situations, it's more nuanced. In summary, the goal of screening is to catch early signs of disease before symptoms develop when a cure is more likely. No medical test is 100% accurate, and screening tests always come with a chance of a false positive or a false negative result. Screening tests are intended for use when there's a high prevalence of the disease in the population the patient belongs to. A personal and family health history is needed in combination with data for geographic area, gender, ethnic background, lifestyle, and other factors to determine how likely it is that you have the disease before testing, the pretest probability. If a screening test is used when there is a very low pretest probability for the individual, false positive results are more likely, and it's less clear how the results should be interpreted. Potential harms of screening tests include psychological stress, unnecessary procedures and treatments, and the cost, time, and health risks associated with these. Benefits of screening include catching diseases early when they can be cured or effectively treated. To recap, this lecture introduced the 3 levels of prevention. We discussed screening tests used in secondary prevention and how we evaluate the quality of a screening test and interpret the results. This includes test validity, reliability, sensitivity, specificity, likelihood ratios, and predictive values. Next lecture is about the dynamics of disease transmission, outbreak investigation, and measures of risk used in epidemiology.